Thank you very much. I very much enjoyed yesterday. I sat in on the training. I found it very fascinating and glad to be here today. You are getting an additional handout being sent out right now to talk about a program you have here in Nebraska, in Omaha, for youth 10 to 14 with sexual behavior problems. And my site is the training and technical assistance site, so we've been working with them. And we'll have a couple seconds at the very end to give you some additional information about that program. Yes, sir. Oh, okay, sorry. I am also recovering from a cold and sinus infection. So my voice, when I was a child, my nickname was Foghorn, so usually I don't have a problem with my voice bellowing across the room, but today it's more of an issue. I run a program at the University of Oklahoma Health Sciences Center for school-age and preschool kids with sexual behavior problems, 12 and under down to 3. And we have been doing research continuously on those programs since '94. And so I'm here today to share with you what we've learned and what we've learned in integrating with other researchers. And this is how I've organized it, so I hope it's helpful. What I hear from the courts and child welfare in regards to this issue as being concerns is, one, when two kids are acting out together, are they just playing doctor, or is it something I need to worry about? And does this mean this kid was sexually abused? And let's say it is something to be concerned about. What should treatment look like? And if they live with other kids, what does that mean? What should we do about it? So that's what my plan is to address in the next hour, to give you an overview of that information. You have my contact information. Feel free. Email is probably the best, but you'll also have my phone number. And Paula presented at the first two presentations. She's excellent. So I'm going to be talking about children with sexual behavior problems. I use that terminology very deliberately because we want to say that they're children first and they have a behavior problem. And trying to move away from the history of using adult terminology with these young kids. So calling them perpetrators or mini pedophiles or those kinds of things lead to very negative perceptions of the youth and practices that are inappropriate for the youth. So thinking them instead of children with sexual behavior problems or adolescents with illegal sexual behavior, although this talk will focus on, again, on 12 and under. Although most parents, I'm guessing that a lot of you are parents, want to believe our kids do not start sexual development until they're 18, at the least 25 preferably. What we know is it actually starts in utero. And so we know that there is knowledge and behavior around private parts that is typical and doesn't seem to be associated with any harmful ramifications of the youth. We do know from research, particularly by Bill Friedrich, that there are cultural variations to that. So what is considered and found to be typical generally in the United States is different than Northern Europe in some ways. So one study that he did found that the parents of young children in the Netherlands and in Finland reported that their young kids liked being nude, and we're talking about preschoolers, 2 to 5, touched their mother's breasts, and touched other kids' private parts at a higher frequency than what was found in the United States. If you know anything about these cultures, they have a more open perception about sexuality, and privacy rules are less stringent than in general in America. Another study Jeffrey Thigpen did with a conservative group of African American families in Illinois found the opposite, that in that population they actually had less sexual behaviors than typically found. What's important in this cross-cultural research is that there are some behaviors that are not found as typical in any population. Aggressive, coercive, planned sexual behaviors are considered atypical in all cultures. I'll talk a little bit more about typical and atypical in a little bit. Sexual behavior problems, in contrast, are behaviors that are child-initiated, that involve private parts, that are developmentally inappropriate and potentially harmful to others. It's key to think about this as being child-initiated behaviors, to initiate the sexual behaviors. We're not talking about all kids who've been sexually abused, but we're talking instead that kids who initiate sexual contact with others. Even though the term sexual is in the term, don't think that that means that sexual gratification is the motivation. In fact, I have found over my over-decade work with it, it's very rarely the motivation of the initial behaviors. It may be anxiety-driven. It may be curiosity, imitation-driven. But very rarely is it driven for sexual arousal. And certainly not deviant sexual arousal that you see in adult pedophiles. Oh, I did it again. Okay, good. It's not a clinical diagnosis. So for you mental health folks and needing to treat this, you don't have a DSM or ICD code to get reimbursed for sexual behavior problems. And actually, I'm a fan for not having this as a diagnosis, because instead it's related to other diagnoses, and it's important to have those things in consideration for your treatment planning. So it may be a symptom of a disruptive behavior disorder. It's a kid who breaks rules, and this is one of the rules they break. And so the treatment needs to be around consideration of their disruptive behavior disorder pattern. It may instead be a trauma symptom, a PTSD symptom, or adjustment disorder symptom. In those cases, you need to be treatment planning and thinking about how to address the trauma as well as the sexual behavior problems related to it. We're going to go from here to talk a little bit more about typical sexual development, sexual behavior problems, but I want you to remember that this is a continuum. It's not like there's one big line. Here I'm doing sex play, here it's a problem. And so that makes it a challenge to you as you're trying to get the information to figure out how to respond. So what I have are some guidelines for you to think about. Something that's helpful to you as well as to the parents that you work with is to try to think about sexual development occurring in the context of all the other areas of their development. It's not a silo effect. So we know that preschool kids don't learn well this way. So if this was a bunch of 2, 3, 4, 5-year-olds, I would have chaos on my hands. You know, they're learning, they're curious, they're imitating things, they're getting their hands and mouth and all their body in the whole learning. They're asking lots of questions. They're very egocentric so that they see the world through their own eyes. And they're making decisions based on what feels good and what doesn't. How do I avoid consequences and seek things that are going to be good? So those are typical things for kids that are young, preschool kids. That can inform you to think about then what would make it sense to be typical behaviors for preschool kids that involve private parts. What do you think? What would be a typical behavior for preschool kids that involve private parts? You show me yours, I'll show you mine, yes. They're curious, and so they'll look at mom or dad in the bathroom. They'll look at brothers and sisters in the bathroom. It's not unusual for them to be curious, to ask questions, to use words they hear and not really know the meaning of those words. Such as, I don't know if everyone can read this. So there's a boy on top of a girl. Okay, we took off our clothes. I got on top of you. How long till it feels good? I don't know, but I've got a headache already. So some guidelines to think about. All right, this may be just a typical behavior. Typical sexual development behaviors that are interpersonal, or sex play, or playing doctor, should be spontaneous, not planned. Happen every once in a while. Curious and exploratory in motivation. Happening between kids that should be playing together already. And not accompanied with any kind of negative, heavy emotions. So no large anger, fear, or depression. They may, particularly the older kids, be a little embarrassed when someone finds out, and should be, but it's not accompanying with this a big negative. We know kids can't consent, but there's no dissent. There's nobody saying, no, I don't really want to do this, and being forced or pressed to do it. So an example I like to give my poor daughters, they'll be appalled if they knew I give them as examples. So my now 9-year-old rock and roll girl used to be Princess Fairy Girl when she was 4 or 5 years old, and she had girlfriends, and they loved, of course, dressing up in princess dresses. So I left and I came back, and her 2 girlfriends were half dressed, half not dressed, slapping each other on the bottom, giggling their head off. So they were breaking a private part rule. They were touching each other's private parts, right? Was that a sexual behavior problem? No. So what do I do in response to that? I'm going to jump a little bit and then come back to this. Well, we recommend when you define it as a typical sexual behaviors, parents will often ask, well, do I ignore it? Well, the answer is no. You take it as a teachable moment. Just like if your kid steals gum from the store, do you ignore it? Or you take that opportunity to teach them about societal rules. So this doesn't mean 2-hour lectures or encyclopedias being brought out for them to read, but targeting some information to teach them that fits where is their curiosity. So my girls were curious about body parts, right? So what I did is I said, left and brought back leotards, had them all put on their leotards, and I said, we have a rule, got to keep private parts covered. You're welcome to change your princess dresses, but you have to have leotards on. So they went into the bathroom one at a time, put on their leotards. And then afterwards, I checked in with my daughter about her curiosity about body parts. And just letting her know it's okay to be curious, but you need to come talk to me rather than touching private parts. And I also told her friend's mom about it, who thankfully took it the same way I did. So finding some targeted areas to communicate. So what do we know about sexual play, typical sexual behaviors? Most of this research is done with adults, asking retrospective thoughts about their experiences. Did it happen, and how did they feel about it? And what we have found in this research, that it occurs throughout childhood, not just preschool. So Freud's latency period, it didn't go away, they just learned how to hide it. And it occurs with kids they know already and play with. And that includes siblings, and that includes same sex. Particularly those school-age kids, they have separated. So girls are playing with girls and boys are playing with boys. And so when they're curious, that means they're touching other boys or other girls. The research suggests it has no relationship to long-term sexual orientation. It's based on who they're playing with. They report most of them are never found by their parents. And the reaction to the behaviors is typically either neutral or positive. The exception is with siblings, and this is my interpretation of the results and from my work. When preschool kids are siblings and touch each other, there isn't any long-term necessary negative thoughts about it when it's sex play. I'm not talking about sexual behavior problem, I'm talking about sex play. When they get into the school years, 8, 9, 10, the older they get, it becomes more problematic psychologically because they know that's just not right. In our society, it's taboo for that to happen. So it does end up having some negative consequences, particularly for the girls. The other thing that I've seen happen clinically is that some sex play may occur between brother and sister at a young age and then stop. And then the boy hits puberty and he remembers that and he becomes more coercive. And then the girl is confused. Well, I did it before. What's going on here? And so, and you may not get that information when you're first meeting with them because she thinks she was part of it, but then after a time when you work with, you realize there's been some coercion or force involved in the situation. Any questions about typical sexual development before I go into the guidelines for problems? Am I doing okay on time? I ran over before. Okay, so some guidelines to think about. If this is occurring, it's more in the concerning or all the way to the problematic. So looking at what was the behavior done between the kids. Is it something that you would suspect would occur if you're curious? Or is it way more than that? So did it involve really explicit sexual acts, penetration, unusual sexual experiences? Then you're going to obviously be more concerned. Look at the frequency and duration. And for those clinicians, the Child Sexual Behavior Inventory written by Bill Friedrich has norms, and it's very helpful to help you figure out if the rates of the behaviors are more frequent than should be typical for their age and gender. So kids that are doing, who have a playing doctor once, not a big deal, but are they playing doctor every time they see each other, and it's all they seem to want to do? That's going to be more concerning, more problematic. Anytime coercion, aggression, force, planned activities going on, that's a huge red flag as being a problem. And when people are harmed, obviously, by the experiences. Oftentimes when kids break rules, they're testing. Parents respond, teach them the rules, supervise them more, and they learn how to follow rules. So a kid, for example, my daughter did this with her friends. They learned and they didn't do it anymore. But if despite parents' intervention, it keeps happening, then you're going to be more concerned. We worked with a blended family. A 12-year-old boy kept peeking into the bathroom when his stepsisters were showering, kept masturbating in the middle of dinner. How lovely. And the caregiver had a very wonderful response to that. You need to touch yourself? Get in your bedroom by yourself. We don't want to see it. It's all right if you do it, be by yourself. And upped her supervision, gave very clear feedback about what's okay and not okay. He didn't desist. If anything, he probably increased it. His stepsisters were very uncomfortable with it. And so that was clearly a sexual behavior problem. And we'll talk a little bit more about him when we talk about placement decisions. Age and developmental disability, developmental differences. Some states have a clear rule, 3 years apart, 5 years apart. I honestly didn't ask if Nebraska does. I would encourage you to do a couple things in your thinking in regards to that. If there is an age difference, and there's not a standard number that I think that makes sense for all families, but certainly if there's 5-year difference, that's going to be concerning. But there are 2 8-year-olds that may be acting out together that are also very different developmentally, that I would consider it a sexual behavior problem, even though the behavior looks like sex play, but one of those 8-year-olds is functioning like a 3-year-old. So take into account their functioning. Is this someone they should be hanging out with already when you're making a decision? Is this something that would be more of a problem? A particular area that can be concerning is our youth with developmental disabilities such as fetal alcohol syndrome, who may tend to play with younger kids because that's where they are, to help prevent this to occur when they're getting the age of hitting puberty, that they are going to need closer supervision because they may make poor decisions about these surging hormones with no cognitive abilities to really make better decisions about those behaviors. Siblings, it's interesting. Again, I would consider it something more that will need clinical intervention the older the kids are. How many children with sexual behavior problems are there in the United States? We have no idea. None. Part of the difficulty is no single entity takes charge of these kids. Sometimes they're involved in child welfare, sometimes they're not. Sometimes they're involved in juvenile services, sometimes they're not. So we have no really systematic way to track these youth. Some people suggest that we are having more of them now than previously, but we don't know if that's because we're doing a better job identifying them. There has been some thoughts that the increased exposure to sexual materials through the media have increased awareness of sex of overall normative youth, and that has increased the sexual behavior problems. But honestly, we don't know. What do you guys think? Do you think there's an increasing number of youth with sexual behavior problems in your own community?
I just think we know about it.
You think we know about it more?
I think there's definitely some issues with computers and same technology, and we've definitely got it out there a little bit more than we used to.
Yeah, and the cell phone with the photo camera technology is bringing a whole layer of problems, not realizing the felony implications of their behaviors. The research in me used to have like 40 slides on this topic with lots of numbers and percentages and data, and I'd see people glaze over. So I have one slide for you about sort of the overall of these youth. We know it's boys and girls, it's not just boys. In fact, my preschool program has more girls than boys. We're about 65% girls, 35% boys. Our school age is a little bit higher boys than girls. And they tend to have co-occurring problems. So just like Pam said earlier, you don't usually see substance abuse by itself. You don't usually see sexual behavior problems by themselves. They tend to have other difficulties like rule breaking or trauma symptoms. And the other thing to not forget is that language and learning problems are pretty significant in these youth, and they've been labeled a behavior problem in the school and often are not getting the educational needs met. So that's an important part of their treatment. Relationship issues. These kids create a great deal of stress for the parents, and they tend to lose their natural support system when it's this kind of behavior. You can talk to your neighbor if your kid steals, but you're not going to talk to your neighbor if your kid touches another kid. It tends to really make them lose natural support systems. And there's a lot of myths and misunderstandings and emotional reactions. If the caregiver has their own trauma history, it brings all of that for them. So it's very stressful. And I'm guessing that you find foster parents frequently find out and make a move. And so you end up having lots of placement disruptions with these youth. People have labeled many of these kids of having an attachment disorder. But I will say, in my over decade work with them, I don't see a pattern of problems attaching with others. If anything, what I see are caregivers struggling with their attachment to the kid. Because again, of all their negative perceptions of this kid, what does this mean? Is there a pedophile? It brings up all their own issues. That our work has been with helping the caregiver attach or reattach or rebond with their child. They will often have peer relationship problems, predating. There's a subgroup of these kids that I affectionately call my geeks. They just, they don't know how to interact with other kids, and so they end up interacting with younger kids and making poor decisions. But then also, once their peers find out they've broken sexual behavior rules, they'll often be ostracized and have other peer relationship problems. Oh, I did it again. Origins. Where does this come from? When we first started in this field, the belief was they've all been sexually abused. In fact, when I started my preschool group, that was my assumption, that I was going to find 85% of them, 95% of them have been sexually abused, and the other 10% we just didn't know. But then I was finding when actually it was about 35%. But, you know, we all know, I'm preaching to the choir to say it's very hard to confirm sexual abuse with preschoolers, right? So I started asking a million questions about any reasons why you should suspect sexual abuse even though you didn't confirm. And it ended up, I think, around 50% of the kids probably or were sexually abused. And 50%, we really didn't have any good evidence except for their sexual behaviors that they would have been sexually abused. About that same percent is what we find in our program for our school-age kid. It depends on your population. If you're a child advocacy center, you're going to have a higher percentage of those kids with abuse histories, right? So if it's not sexual abuse being the only reason why they have sexual behavior problems, what's going on? Bill Friedrich had a large sample, over 3,000 kids. Some had been sexually abused, some had not. Some had sexual behavior problems, some had not, and looked at what predicted them having sexual behavior problems. Models of sexuality, so the sexual abuse and types of the sexual abuse, exposure to nudity and so forth. Models of coercion, and what he looked at was physical abuse and domestic violence. Family adversity, which he defined primarily as a single caregiver, poor, uneducated, or low education. And then child vulnerabilities, emotional and other behavior problems. And most people would have predicted that models of sexuality would have been the highest variable predicting future sexual behavior problems, when in fact what he found was models of coercion. This fits what we know about kids who break rules. There's tons of research on children who develop oppositional defiant disorder, conduct disorder, antisocial behaviors, delinquency, and that is raised in a coercive caregiver environment. And the extreme being experiencing physical abuse and witnessing domestic violence. So a big subgroup of our kids are kids who have learned from what they see to break rules. Models of sexuality also was a strong predictor, particularly when the sexual abuse occurred when they were young. So it's much more likely to occur with preschoolers who have been sexually abused than school-age kids who've been sexually abused. You're looking confused by that. So you're surprised? No, okay. And it's more likely to occur, that it's more likely to have sexual behavior problems when the sexual abuse happens with multiple perpetrators and with penetration. And so think about it. So what this young kid is learning is how you interact with others is very sexual. And so they're learning about the world, and this is what they're experiencing, and then they're imitating it and repeating it. I would say in my own clinical work, I would add to family adversity caregivers who are substance abusing or depressed or otherwise unavailable to provide guidance and support. And then to the child vulnerabilities, the language problems and impulse problems that some of our kids have. So you can have a kid who've experienced trauma and do well, and kids who experience trauma and don't. And those who do well are more likely to have caregivers that protect them, provide guidance and supervision, have open communication, model healthy boundaries, and provide better coping skills. And the coping skills are more likely to happen if the kid is bright. So if you have language problems and learning problems, it's going to be hard to cope by thinking about the silver lining or understanding it in a different way. Instead, they're going to imitate what they experienced and find things to distract that sometimes are maladaptive behaviors. Any questions? I'm changing topics now. Any questions about origins? I'm going speed, light, fast on through all this. Are you surprised? Some yes, some no. All right, so I'm going to go through some myths about these kiddos. For your community, can these kids, once they've been identified as a youth with sexual behavior problems, can they still attend public school? Yes. Yes, okay. So, and that's what we find, that youth with sexual behavior problems, most of ours do attend public school, do well. You have to make an individual decision about what the school needs to know and how much they need to know in order to make sure all the kids are safe. And part of that is inquiring about how do they handle bathroom time? How do they handle recess? How do they handle unstructured times? Can they provide good supervision? I had one fabulous teacher who, this is a kid that really needed to be closely supervised, particularly in the bathroom. And that can be handled in a very stigmatizing way or in a better way. And what this teacher did is she made him the bathroom monitor. So he could only go in by himself after all the kids went to the bathroom, because he was going to make sure nobody TP'd the bathroom, nobody wrote on anything. So he was sort of almost given kudos, to do this, rather than being ostracized about it. And then she always knew that he wasn't in the bathroom with another child. Can they live in the community? The treatment, and I'll talk about treatment outcome in a little bit, that works is outpatient cognitive behavior therapy with the caregivers. You've got to have the caregivers involved. And typically they can successfully live in the community. You want to be thinking about a more restrictive environment, residential or inpatient care, for those youth who have really severe aggressive coercive behaviors that's not responding to outpatient services and parental intervention, and kids with other psychiatric issues that they need to really monitor much more closely, at least until they can get them stabilized. Kids who are suicidal, kids who have psychotic symptoms, and so forth. Sometimes what happens is treatment and placement issues get merged. So with that youth that I talked about before, about his sisters being very uncomfortable with him, and I would too because of his behaviors, he actually had no problems at school. Straight A student, no peer problems. He could have continued to live in the community but no longer live in that house. There was no relatives and no foster home available. So he ended up inpatient. So, as part of the systems issues is to think about how can we better support these youth in the community. Will they grow up to be adult sex offenders? That's the big worry. That's why some states put them on lifetime registries, because they think it's very likely that they're going to grow up to be adult sex offenders. So I'm going to give you the results from our work. Early in the 90s, Barbara Bonner did a treatment outcome study. We compared cognitive behavior group treatment to a dynamic play therapy group for 6 to 12-year-olds. All kids with sexual behavior problems, 6 to 12, so they were randomized. They got one of those two groups. While Barbara was doing this, I ran an ADHD clinic. So I had a group that we call the comparison group here, 156 comparison. These are kids who had behavior problems, but no sexual behaviors. Then we got permission to match their name, date of birth, social security number with our child welfare data, with our juvenile data, and with our adult sex offender data, and tracked did they get a future sex offense over the next 10 years. So this is my big data slide, and I'll go through it with you. So down here is time. 1 year, 2 year, 3 year, 4 year, 5 year, all the way up to 10 years. And this is called a survival analysis. And to survive means none of that group got a sex offense. When a member of that group or more members of that group were referred for a sex offense, then this line goes down. So if the line went down to here where it says 0.5, that would mean half of the people in that group had a sex offense over that period of time. Are you following okay? All right, so what did we find? Well, the first take-home message is look at all this white space. I'm guessing if I would have asked you what percentage of them had a future sex offense, I would be hearing 50%, 70%, right? No. So the worst group was 11%. 89% did not. Second take-home message, type of treatment makes a difference. So this top dark line is the cognitive behavioral group. This dotted line is the comparison. So with 12 weeks outpatient of cognitive behavior group, they look no different than kids that never had sexual behavior problems in the first place. With the play therapy group, again 11% had future sexual behavior problems. Questions? What time is it? I don't have my watch.
It's about
20 after, and I need to be done in 15 minutes. Okay. All right.
Question.
Yes.
This were for children who had engaged in those behaviors between 8 and 12, correct? Did I understand that?
6 and 12.
6 and 12.
Yes.
Was there similar studies done between 12 and 16, or and did that show similar results if there was some study?
There has been research with adolescents. I have colleagues who are more, that's their expertise, but I'll give you what I hear from them. The randomized clinical trials have all been with multisystemic therapy, and those outcomes are outstanding, similar to this. The other ones are going to be uncontrolled trials, so they follow those kids over time, but they don't have a comparison control group, and the findings are around 12%.
Okay.
Yes?
The play therapy, 11%, that was untreated or in any fashion?
Was play therapy untreated? No, they were treated with play therapy.
Okay. What I'm trying to find out is what treatment was afforded the 11%?
The play therapy.
Does that also extend to comorbid diagnoses?
It was a randomized controlled trial. So at this point, a bunch of kids were collected, and they were at flip of a coin. You either went to cognitive behavior or you went to play therapy. So there was not that the people in play therapy weren't different than the kids that were in the CBT approach.
Or was it double blind?
Double blind? No, no. Well, I can talk to you more about the play therapy. There were some parts of it that made this even better results than other research with play therapy. Yes?
Is your data showing you that the cognitive behavior therapy is more effective than the play therapy?
Exactly.
And why do you think that is?
I'll tell you. If you look at the research and there's been lots of research on disruptive behavior disorders. There's been about 11 studies on kids with sexual behavior problems. And we did, I'll jump ahead to this, we did a meta-analysis. So we looked at all the studies that looked at kids with sexual behavior problems. And we didn't want to know if treatment worked. What we wanted to know, what is it about treatment that makes a difference? What component of treatment is really essential to work? And if you don't leave with any other message, leave with this. You have to work with the caregivers and teach them how to raise their kid in a way that teaches them the right rules about how to interact with others. These kids have learned the wrong rules. It may have been because of trauma. It may have been for other reasons. It may be that they saw porn. It may be that they saw their big brother have sex with his girlfriend. They learned the wrong rules somehow. And the key to learning the right rules is not getting into the head of the kid and have them learn their cycles or do any of that adult sex offender. The treatment is work with the parents. Teach the parents how to supervise their kids, how to communicate to them about intimacy and sexual matters, and how to choose friendships and relationships. Have consequences when they break rules. So they learn it's not okay to do these behaviors, and reinforce when they make good decisions. That is what works for problematic behaviors, and that's the essential core of the treatments that work. Trauma-focused CBT also works for sexual behavior problems for those kids that have PTSD, post-traumatic stress disorder, and sexual behavior problems. In my work with Cohen and Manarino, who are two of the developers, they suggest with the older kids that you supplement it with more safety planning and a little bit more work around boundaries than is standard. But not all these kids have PTSD. In fact, it's not a lot, and it's probably about 15%. Again, depending on your population. I mean, there are some subgroups I worked with where there's so much trauma in the community. All the kids have PTSD. All the components that are related to good outcomes for sexual behavior problems involve the caregiver. So the other components are teaching them about rules. I'm jumping ahead a little bit here. So teaching them about rules and boundaries. Our preschool kids, I don't know if you had 4-year-olds run up, give you hugs, tell you they love you, crawl in your lap, you just met them. They need to learn good boundaries. They're at risk for being abused. In fact, our 10-year follow-up suggests they're at as greater risk of being a victim in the future than having a future offense. So the other component was abuse prevention. Teaching the caregiver how to prevent future abuse experiences. And sex education. In my interpretation of the sex education results, we're not making a huge difference by teaching kids about sperm and eggs. The difference is we're making that parent and kid sit down and talk about it, which they never have done before. And the kid learns, okay, I can go to my parent about these questions. And that's who they should be going to, and not to their peers, and not to their older brother, and not on the internet. So helping that dialogue happen, so that's who they go to when things come up in the future. So it's a very structured program. Here's the recidivism result of our adolescent program with illegal sexual behaviors, 5 to 12%. And the more caregiver involvement, the lower that recidivism rate. So what do you look for in qualifications? You want licensed professionals trained to work with youth with sexual behavior problems who understand normative and problematic behaviors and approach the problematic behaviors by working with the family and understanding the system. Don't run away from this with coming saying play therapy is bad. That's not what I'm saying. I'm saying play therapy doesn't work for this. So if what you're hearing is that the therapist is with the child alone, the parent has no idea what the goals of treatment is, then I would say maybe this is not the best fit here. Maybe we need to look at something else. You also want providers trained in trauma and being able to address the trauma-related symptoms that may occur too. Best, they may have acted out on their sibling, and their sibling has PTSD and they have sexual behavior problems. And part of the program that we'll be talking about you at the very end, the goal is to work with the whole family rather than cutting them up and siloing them out, so that if you have an agency who can address both the trauma symptoms and the sexual behavior problems and help the whole family develop a healthy pattern of behavior, you're going to get reunification faster, you're going to get kids out of foster care faster, and you're going to not have to be so dependent on residential care and inpatient. And you guys are already doing this. I mean, the key is to have a working relationship across disciplines in order to do this work. I was talking with Vicki Wise earlier about getting this program involved here, and I think teaching your providers, especially if they know trauma CBT, that can be done readily. The key is getting the whole systems to be getting them and working together, and you guys are doing that, so that's awesome. So placement decisions. I've worked in some states where all the kids go to residential care. Delaware, for example, recently called me and said, we have no outpatient care, so they all go to residential care. So they get shipped off, parents are too far away, know nothing, and then they get shipped back 2 years later. It's not working really well. Well, no surprise. But the question is, I mean, some of these youth might need it. How do you make this decision? Most kids are able to be addressed in outpatient. The key factor is often less the child than do you have a caregiver who can supervise, monitor, and make sure they're making the right decisions, and making sure that there aren't opportunities to break the rules. Other things to look at: degree of self-control. Are they responding to the parental intervention? Are they responding to the outpatient treatment? And how much are there other things going on? Again, those youth with more psychiatric issues.
Are there any standardized assessment tools for where a child might fall on the continuum on the front side?
The only normative measure on sexual behavior problems for kids is the Child Sexual Behavior Inventory. It is not something that you'd ever want to just take those results and make decisions just based on that. It really takes a clinical judgment. Most of the time when I'm talking about a kid needs inpatient or residential care, it's not the sexual behavior problems that I'm mostly concerned about. It's these other aggressive behaviors. It's the non-responsive to supervision. And so it really takes a thorough big picture evaluation of their behavioral adjustment, their risk to harm self or others, that even beyond the sexual behaviors.
I guess, but when they come into court, you've got that continuum. Maybe I've got one acute incident. Do I automatically jump to the big full level assessment? I guess whether there's some type of screening that this was, that isolated incident that you talked about. Maybe it's got one of, we had your guidelines. We've got 7, 8 of them. Maybe we've got one, maybe 1.5.
What I would probably do is think about probably outpatient first, and our assessment takes 3 hours. And we're able to make those decisions in that. I mean, I don't know what else, other resources that you have. We also have a 2-step thing. So we do an initial screening in regards to, I mean, some of the times they call us and it's really clearly just sex play. It was a 3- and 4-year-old in the bathroom and mom's freaking out because the 4-year-old boy touched his 3-year-old brother's penis in the bathtub. We don't need to see him. Other than we will bring mom in to do some education. We'll give her some booklets and pamphlets and help her understand, because obviously she doesn't even have the basic. So what we could do is talking about how to help. And also you have some great resources in Omaha that can help you with that process too. Be wary about aggregating these kids in residential care, because what happens without appropriate monitoring and so forth, they actually learn more maladaptive behaviors than get help. In fact, yesterday, one of the judges afterwards came and talked to me. They're concerned because in residential care, he's accessing porn and doing all of this. And my question back to him is, how is he accessing porn in the residential care? I mean, why is that happening? So there are potential negative effects on the youth through this aggregation of the youth. All right. I want to make sure we have time for the RSAFE program, and so the 2 resources for you. They had a couple slides. Can we bring those slides up on here, or did you not put it on here? Oh, okay. Well, you got a couple slides in your handout that is about the RSAFE program. There is an article I want you to be aware of that we wrote with the judge, Judge Stewart, for judges in a judge's journal. So that might be helpful to you. It gives you much more detailed safety plan and detailed information about what I presented today. And then there's some other resources at the end of your PowerPoint of professional agencies and fact sheets, free fact sheets that you can download and use with families on sexual development, sexual behavior problems, and how to dispel the myths.